So we'll start with Manuel Lopez Cano. You all know Manuel. He's an expert surgeon from Barcelona. He will host the next EHS Congress in 2023. And we give the floor to him to tell him his tips and tricks on parastomal hernia repair. Manuel.
Thank you very much, Mark and David. Thank you, Mr. Chairman. And of course, first of all, thank you very much to Mirka and Victor for the kind invitation to be here. For me, believe me, it's a privilege and an honor to be here. So when I received can I see my first slide? Yeah. When I received the call, the invitation coming from Victor and Mirka, the title of my presentation was Parastomal Hernia Repair, My Option. So I was thinking on that, and finally I realized that I don't have one only option. I have different options. So if you allow me, Victor and Mirka, I prefer to change a little bit the title, and from Parastomal Hernia Repair, My Option, to Parastomal Hernia Repair, How to Choose an Option, at least in my case. Here are my disclosures. So before starting my presentation, I would like to give you some reflections regarding parastomal hernia repair. Because when I am in front of a patient with a parastomal hernia, the first thing coming to my mind is primum non nocere. And why is primum non nocere? Because the parastomal hernia repair in the majority of cases is an elective surgery, because we are treating to improve the quality of life of the patient, and of course the patient will win, because as you know, surgery is a path of no return, because parastomal hernia is a hernia with a defect that cannot be closed. It's an incisional hernia that cannot be closed, the gap, and also adjusting this gap in an ideal way is almost impossible, in my opinion. And we have multiple repair options and also insufficient data to recommend one or another. We are adding prosthetic material, and parastomal hernia repair has a very high percentage of recurrences. So sometime I was thinking in front of my patient that I am offering him or her a palliation rather than a cure of the hernia. If we can cure every hernia, this is another question. So how to choose an option? In my opinion, the best way to choose an option is to use the shared decision making model or process. And probably parastomal hernia is a paradigmatic example where apply this way to do the shared decision making model, because the benefit of surgery is uncertain, because we have feasible non-surgical options, and because the surgery is complex, in my opinion, by definition. Parastomal hernia repair is a complex surgery by definition. So what is a shared decision-making process? It's a two-way communication process. We need to give the patient information about the patient's condition, I mean, BMI, diabetes, comorbidity, how to handle and optimize this type of conditions. We need to inform the patient about the treatment options, benefit and harms of the different options, and also inform about the scientific uncertainties regarding the evidence, at least nowadays. And patients should inform us about the values and preferences regarding the different options that we offer him or her. So a lot of time we are in congresses and we are doing talks in panels, and we are speaking about that we are doing our clinical practice in the best evidence way possible. So a shared decision-making process is an essential constituent of evidence-based medicine. Definition. So the shared decision-making process has 3 steps. The first step is the so-called choice talk. We convey the awareness that more than one treatment option is available. And we invite the patient, of course, to participate in this process. The second step is the option talk. in which we inform the patient about the options, pros and cons, the patient's condition, again, morbid obesity, diabetes, comorbidities, our own experience regarding the treatment of parastomal hernia, and also we need to give the patient a reasonable analysis of the evidence in the moment of the consultation. We can use different communication tools, graphics, videos, and so on. And finally, we have the third step is the so-called decision talk, when we elicit patient preferences and we decide together with the patient what is the best option for the parastomal hernia. Sometimes the shared decision-making model is not applicable because patient characteristics or situation. For example, very symptomatic parastomal hernia with a total alteration of the quality of life of the patient, or in cases of emergency situation. Taking into account these previous contexts that I show you in these slides, I think, at least in my experience, that the majority of time I am in front of a patient with a parastomal hernia is, if you allow me, a patient with a simple, in brackets, of course, oligosymptomatic hernia, independently of the size, big size, as the photo of the left, mild or a small size in the photo of the right. But the majority of time, the patients are giving us some difficulties in back appliance, some leakage, or some pain. And we need to start the shared decision-making process. And the choice talk is easy from a parastomal hernia repair perspective because we have only two options, or the watchful waiting option or the repair option. So if we start the option talk and we speak about that, speak about watchful waiting with the patient, we need to explain that the pros of watchful waiting is avoid surgery, of course, is evident. But the cons is that we don't know the natural history of a parastomal hernia. The parastomal hernia can increase in size over time and depends, of course, of the risk factors. If the patient has morbid obesity or another, is a smoker or another risk factors. Of course, we need to talk with the patient that the parastomal hernia represent an impairment in the quality of life because leakage, middle skin irritation, frequent back changes, increases cost, the watchful waiting process, not only in medical material for the patient in bags and so on, also for activity restrictions and loss of work productivity. So we need to take into account as surgeons that when we are talking about watchful waiting for a patient with a parastomal hernia repair, we need to think about that it will be a lifelong counseling. And in the worst case scenario, 15% of the patients, they will have at least one obstruction episode, 35% frequent pain, and 27% repeat episodes of leakage. But when the time to talk about the repair, the pros, of course, we eliminate in brackets the hernia. But the cons is that we have a high level of recurrency, as commented before, related with the risk factors. It's a complex surgery because sometimes we have skin problems, concomitant skin problems, concomitant incision or hernia. We need to look the position of the stomach through the abdominal wall is not can be very lateral, medial, very low. And the possibility we need to speak about with the patient that the possibility of stomach relocation increasing the complexity of the surgery. And also we need to explain the patient that if the parastomal hernia recurs, probably the situation regarding the quality of life in the first surgery will be totally different in this second surgery if we try to repair these recurrences. So when we explain the patient about the evidence, we need to say that the low-level mesh infection in the majority of repairs, if we look at the literature, with low level of complications, and we need to offer the patient the advantages of the minimal invasive approaches. But we have cons regarding the evidence because the majority of studies that you can find in the literature, in the PubMed or other databases, are observationals with a small sample set of patients with short follow-up periods, with a high level of recurrences, and with a totally unknown scenario regarding the quality of life. So you need to explain also your own experience in the treatment of parastomal hernia. And here's our experience. Our cases are inside this database, is our database in Spain, the so-called EBEREG. We recently analyzed 353 patients after an operation of parastomal hernia, and we realized that the level of complications is so high as 30% or 31%, and the level of recurrences with a mean follow-up of less than 1 year is almost 30%. So I explain my patients, even in our hands, the level of complications and the level of recurrences are very high. But of course, I have an algorithm. As surgeons, we need algorithms. We are very happy with algorithms, and I show you my algorithm. It's a dynamic algorithm because I change these options depending on the evolution of my own practice and also on the evolution of the evidence of the data. Of course, the best option for a patient with a parastomal hernia is, if we can close the stoma, is close the stoma. It's the best option. But if not, as is the majority of times, we need to optimize the patient and to perform a computer tomography. It's compulsory, it's mandatory. And we can find a patient with a parastomal hernia with concomitant incisional hernia or without concomitant incisional hernia. In cases with concomitant incisional hernia, I explain to the patient that I prefer to do an open retromuscular plaster repair in order to repair a parastomal hernia, because the evidence, the low level of recurrences have been related with this type of technique. Now, from some years ago, we have the robot as a device to operate on our patients, and I can offer the robotic retromuscular plaster. But I place an interrogation mark because I don't have enough number of patients operate on following this technique in order to explain my patient that we have the same results with open surgery. When the patient is a patient, a parastomal hernia without concomitant incisional hernia, for me it's very important the size of the defect. If the defect of the hernia is very large, I prefer open surgery, resetting the stoma. If the defect is not large, it depends on the implantation of the stoma. If the stoma is very low in the abdominal wall, I prefer resetting the stoma following open surgery. But if the stoma is transrectal, it was sterilized through the rectus muscle, and the abdomen is very hostile with a lot of operation before us. For example, in patients with inflammatory bowel disease, I prefer to do an open-onlay repair. I know that this is a bad technique, but I prefer to do that. If the patient has a non-hostile abdomen, I prefer to do a lap or robotic sugar baker. This isn't my algorithm. Probably another people has another algorithm. So finally, in the decision talk, Victor, my option, and coming back to the title, parastomal hernia repair, what's my option? My option is the shared decision-making together with the patient. So let me, just to show the last slide, just to remind you our incisional hernia prevention at the end of this year in Barcelona. All of you are invited to be there. And also our next, after Manchester, our next European Hernia Society meeting in Barcelona, the first week of May in the next year. All of you will be more than welcome to our Congress. Thank you very much for your attention.